Let's get started. We need to finish up today and have a week. So if we don't get all the way through it today, because there's still quite a few slides, then I'll take it was actually a year before last lecture and put it into this year's playlist so that you can have the rest of it. But we'll get as far as we can go. So really what we did was we got all the way through PA, AP, chest. So now we're going to talk about lateral, and then we'll talk about abdomen and flatten upright abdomen and the things that we're going to be looking for, and certainly imaging and evaluation of those. So lateral chest X-ray, of course, completes the PA and gives us a three-dimensional perspective of what we're looking at. Remembering that on a chest X-ray, we got a three-dimensional structure we're taking a two-dimensional image of, so we don't get any kind of depth perception. Also, thinking about the lobes of the lung. Lobes of the lung, you've got three in the right, two in the left. And the fissures there between them aren't horizontal, so it's difficult to tell exactly where something is just on PA chest X-ray. So something that appears to be in the upper lobe might actually be in the middle lobe, depending on where it is, because the fissures go not just straight across, but they go kind of diagonally like that. So if we've got a lesion right here, well, is it in the anterior part of the upper lobe, or is it in the posterior part of the middle lobe? We just can't tell on PA. So we get that three-dimensional perspective with the lateral. So just the housekeeping things, what we want to see on, or how we want to position for the lateral. I know Merrill says T7. I had that maybe T8, just because you don't see the apex of the lungs real well. And if you're using a 17-inch image receptor and you position at T7 and you got somebody who's got long lungs, then you may very well clip costophrenic angles. So generally speaking, you might lower the image receptor just a little bit for lateral. Don't overdo it, right? But you might drop it down an inch or so. So Merrill's kind of made a shift to two inspirations for both PA and lateral. What you're probably going to see in most cases, and what you may be doing is, you get to, what you may be doing is doing a single inspiration for PA and then a single inspiration for lateral. In all honesty, this is probably what most people do. But by the book, two inspiration for both views, right? But if somebody's doing two inspirations for the PA and then one inspiration for the lateral, that's because that's what it used to be in the Merrills, and they made the shift. I don't remember if it was in the last edition or the one before. So once you get to the registry, what are your breathing instructions for both PA and lateral chest? Two, right, exactly. So what we want to see then is from the apex to the costophrenic angles, just like on PA. We want to see anterior, posterior surfaces. We would need to see the soft tissue of the humeri out of the way, as well as the humeri themselves. So we've got to get them up. If you have one of those grab bars that's attached to the bucky, that makes it pretty easy, right? So you drive the bucky up and it automatically raises that. I've worked in places where they had a good system, provided you used it right, but it was basically a 2x4 on the wall that you would take a piece of conduit and stick in and have the patient hold on to it. So it had holes so that you could raise and lower it, but you had to take the initiative to raise and lower it. You know, seen those? Texas spinal joint. So the problem is that, some people just won't take that initiative, and they'll just, wherever it is, that's where they're going to put their arms, right? And you're going to wind up with soft tissue overlap. So you got to make sure that you use that properly to get that soft tissue in the humerus out of the way. Rotation and tilt, really, we've got, with rotation, what we have is mispositioning of the coronal plane. With tilt, what we have is mispositioning of the sagittal plane. So sometimes the patient will be leaning, and different demographics give you different orientations of that lean. If you have somebody who's got wide hips, narrow shoulders, and you tell them, I want you to put your side up against it, and some of the, their hip hits the bottom of the bucky, they have a tendency to lean into it, as opposed to if you've got somebody who's got broad shoulders and narrow hips, they go the opposite direction with it. They want to put their hips up against it and they lean away from it. The problem with that is that it's going to take your diaphragms, which should pretty much superimpose. You know, you think of your anatomy, your left diaphragm is lower than your right, But with the divergence of the central ray, what it's going to do is it's going to take that elevated diaphragm and it's going to project it inferiorly so that you get the superimposition, near perfect superimposition of two diaphragms. So if the patient is leaning, then, you know, we tend to focus on rotation. You know, get your two fingers up there, and, you know, if it's beyond two fingers and it's not overly rotated, 2 fingers is a lot, really. The positioning book says ½ an inch. That ain't much. So somewhere in between there is what I would settle with. 2 fingers is that's a lot of rotation. So we tend to focus on that, but we don't really focus on, you know, the tilt. So in both cases, you know, the textbook goes through, well, what's the heart shadow look like? Which ribs are more elevated, which is, both of those are valid. To be honest with you, I just can't see the heart thing real well. I've never dialed my eyes in well enough to evaluate that. But there's always something under the left diaphragm that you can use to evaluate both tilt and rotation. What's always under the left diaphragm? Gastric bubble, right. You can always call up a burp, right? So there's always air in the top of the stomach with the patient upright. So what I would encourage you to do is take a look at that. Where is it, right? So we'll take a look at those here in a minute. But anyway, once the diaphragm superimposed, if they're not superimposed, it implies one of 2 things. Either one lung is not functioning right, or maybe, you know, the patient has cirrhosis or something, and their left diaphragm is, you know, their liver's enlarged and their left diaphragm is elevated, or they're leaning. So another thing that we need to be aware of is whenever we do, let's say we're doing a PA and lateral, and we do a lateral with the patient seated on a stretcher, we can run into a little complication there. So the textbook calls the positioning error here foreshortening, but it's not really foreshortening. Foreshortening, remember, is a specific thing, and that's a tilt of the anatomy in relationship to the central ray and image receptor. This is compression, really. So when you read that, you know, the foreshortening, the anterior lobe of the lung, it's really compression. Because think about it. You're sitting, and, you know, if you're doing a lateral chest x-ray because of the way the patient's going to be leaning, you want them sitting up as much as possible, 90 degrees if at all possible, right? So if you're doing a chest x-ray, lateral chest x-ray with a patient on a stretcher, how healthy are they?
Not very healthy.
Not very. How young are they?
Not very.
Usually not very. I can tell you, the older you get, the less flexible you get, and it's hard to set up at 90 degrees. Okay, if you can get that, and also the older you get, the more fluff you wind up, you know, accumulating. So you try to sit this patient up to 90 degrees, and they got this beer belly that we were talking about last week. Where's that gonna go? Into their thighs, right? So basics of hydraulics is you can't compress fluid. Okay, so what is all that essentially? It's fluid, it's mass, it's soft tissue, which is primarily fluid, right? So if you can't compress fluid, it's going to go somewhere. So you set the patient up, this goes into the thighs, which can't be compressed. It might displace a little bit, but it's going to push up. And what that's going to do is prevent your, you know, your inferior lobe from inflating. So not really foreshortening, it's compression, but okay, whatever. We'll call it foreshortening because that's what, you know, Martensen likes to call it. But it's really compression, okay? So a better position for your seated lateral is not to put the patient all the way up. Maybe lean them back just a little bit to eliminate some of that. Spread the thighs out a little bit so that their beer gut can go kind of in between the thighs. Whatever, just try to keep that from happening. So good lateral chest x-ray, we have almost no rotation here. And really, that's not much more than 5% rotation. Can you see the anterior, or the superimposition of the ribs? They're not perfectly superimposed. That's probably not much more or not much less than a half an inch. I would be hard pressed, even if the rotation was slightly more than that, to repeat that because that's pretty good lateral. Hey, you know, real gut check here. How hard is it to get a perfect lateral chest X-ray? It's almost like getting a perfect lateral knee, right? It's just not as easy as what it seems like it should be because of the number of them that we shoot. You know, the patient's going to be rotated just a little bit.
Could that not be partially also due to the divergence of the knee because you have the right
Potentially.
so much further than the left ribs?
Potentially, yeah. Yeah, I hadn't really considered it, but potentially, yeah. You got magnification of the upside and divergence of the central ray may exacerbate that.
So doesn't that literally mean if you want a true lateral, and there's magnification going to be there regardless.
Mm-hmm.
A true lateral on our end really isn't a true lateral.
That, you know, you put those two things
Man.
together, yeah.
That's
you know,
weird.
Yeah, y'all making me think this morning, but yeah, potentially, yeah.
Check that out. But
Yeah. So we're done for the day.
Yeah.
But so I mean, both of those very good points. It's hard to get that perfect superimposition. I won't say it's impossible because you do it sometimes, but it's to consistently get a perfect lateral, or the appearance anyway of a perfect lateral is very, very difficult to do. So, you know, give yourself a little bit of leeway. You know, you see a little bit of separation there. Blame it on the divergence, blame it on the magnification. Wasn't my fault. You know, most of the time you blame your patient, right? You moved. Even if you didn't, you moved. You must have breathed. Whatever. Well, now we got something different we can blame it on. So make sure that you get them in as good a lateral as possible. Okay, so what I recommend that you do is tell them, you know, point your feet directly at that wall. Now, I want you to touch this thing. Don't tell them put your side up against it because they will, right? So if they got broad hips or broad shoulders, they're gonna, you know, do this thing. And if they've got broad hips, they're gonna have a tendency to lean into it. So I really recommend you kind of stay away from that description as much as I just want you to get up against this thing, right? So the purpose for the lateral, again, we're going to do lateral because where is this? We know it's in the left lung, so it's in one of two places in the left lung, either superior or inferior lobe. Even with where it is pretty much right in the middle between the two. We can't tell from that. So this is a good description. Can you kind of see that little goober this guy's got in his upper lobe? Well, what appears to be upper lobe on the PA. Can you kind of see that density or loss of density? Okay, so on that, you can't really tell where it is, but if we put the AP and the lateral together, the PA and the lateral together, we can get a better idea of where it is, right? So most likely upper lobe. Even then still, you know, they're going to have to do a biopsy of that to determine exactly where and what. So fissures, you know what the fissures are, you know what the lobes look like, and the lobes travel again on a bit of an oblique angle, but look how high the inferior lobe goes. I mean, it goes way up there for being a lower lobe. Okay, so just added in some pathologies. Some we're going to just kind of skip over, some we're going to stop and talk about. So lateral evaluation, again, we want to go from the apex to the costophrenic angles. We want no overlap of the soft tissue. We want to see front and back, no rotation. We want to see those diaphragms superimposed. If they're not superimposed, you need to go back and look at your PA and see if there's a reason for it. You know, if there's maybe, you know, gastric bubble is up in the lung, indicating that the left lung all by itself did not inflate. So we talked about that last week. Maybe an obstruction, being an obstruction because, you know, they aspirated something, or possibly they've got some sort of pathology that's blocking that. So do we have a locked hemidiaphragm? You know, is it a diaphragmatic nerve issue? Is it pathology? What do we have going on? And then proper image replace, IR placement, collimation, and marker as well. So remember that your body habitus is going to determine your collimated field direction if you have somebody who's tall and thin. I say start with hypersthenic. With a hypersthenic patient, almost universally you're going to need a more rectangular image, or at least collimated field if your image receptor size is all one. It's going to be more broad and less long. If you have an asthenic patient, it's going to be more narrow and longer. And if you have somebody who's sthenic, and especially somebody who's hyposthenic, then you're going to be looking at somebody who's going to have all. You know, they take in a breath and they just expand in every dimension, and it goes on forever. You know, their lungs go out to their fingertips and all the way down to their knees. And if you're using a 14 by 17 size image receptor, good luck, really, because with somebody who's got that hyposthenic body build, your positioning has to be almost perfect in order to visualize. So what if you use your image receptor, you got that patient as 14 by 17 image receptor, and you put it in lengthwise, and you have a patient take in a breath, and you get the costophrenic angles, maybe not, you know, because sometimes your chest kind of comes back in, right? So your positioning is perfect, but the patient's projected off the image receptor, and you use 72 inches. What would you do? If they took up the entire 17-inch length, pretty much, and you got from the apex as far down as you could get, but they breathed themselves off the image receptor laterally. Repeat. Should. You didn't include all the anatomy, but what would you do? You missed both sides. There you go. So you put it, you essentially just shoot for that lower end, right? You take your image receptor out, you put it in crosswise, you're not going to fit them on there crosswise either. But what you could do is just shoot the bottom side just to, you know, make sure that you got everything, right? So understand limitations of your equipment and what it is exactly you need to shoot. Like, this gets into the next portion of this, but let's say you shoot a KUB on a patient and you miss the B. Do you need to go back in and shoot a whole new KUB? No. The answer is no. Bladder shot's going to be fine, right? So, common mispositioning errors, we already talked about all that, so we're not going to go back into it. Mid-coronal plane for a lateral should be perpendicular to the image receptor, parallel to the central ray. So we're going to look at the ribs to determine rotation. We're going to look at those hemidiaphragms. And again, the textbook goes into the shadow of the heart. And, you know, again, full disclosure, I just have a hard time seeing that. So the reason we do left lateral is the left ventricle is larger than, you know, any other part of the patient, unless, you know, you got a patient who has dextrocardia, right, or situs inversus, and then, you know, it's still the same anatomy, it's just flipped around. So there are times to do a right lateral, and those will be those cases, but in most cases, your patient's not going to tell you that. You're not going to find out that they've got a flipped heart until after you've already shot the PA. So unless you look at your image before you shoot the lateral, you're just not going to know that, right? So if we have rotation, then what's going to happen is, let me get this guy. So if we have rotation, again, pretend that we've got the arms elevated. If we got rotation, we're going to have separation of the posterior ribs. So which way is the patient rotated? Well, again, take a look at the gastric bubble. The gastric bubble is going to be under the left hemidiaphragm. So if the left hemidiaphragm is posterior, then what do you have? The left side is posterior and the right side is anterior. So that's your rotation. What you would do is go back in and repeat that, you know, providing the rotation was significant enough that you would need to repeat it. And remember that as you rotate, one side's going in one direction and one side's going in the opposite direction. So your tendency on repeats is to look at how awful that rotation is. Well, it must be the patient's got some funky anatomy, so we're going to rotate in the opposite direction. You overcorrect, right? So as you rotate back, you know, the amount of rotation is exactly half of what it looks like. So even on one that you would repeat for rotation, the amount of change that you would need to make on your patient is half as significant as what it looks like, right? So don't overcorrect. Look at the gastric bubble. Where is gastric bubble? If it's posterior, then you rotate it. And what we need to do is rotate the left side anterior and the right side posterior in order to correct that. So if the gastric bubble is, you know, the hemidiaphragm should be superimposed. So if your gastric bubble, let's see if I'm here. Gastric bubble is above one hemidiaphragm, then which way was the patient leaning?
Towards the middle.
It elevated, so they're leaning away from the image receptor, right? If your diaphragms are not superimposed, one's elevated and one's depressed, then the one closest to the image receptor is, I mean, the patient's leaning towards the image receptor, okay? And you're probably gonna know that just based on, you know, the shape of the patient. And you should see that coming really before you make your exposure. You position the patient, you take a look at them, and if they're doing this number, just tell them to, you know, straighten up. All right. So posterior ribs, again, according to the textbook, 1/2 inch. Gastric bubbles, what you're going to be looking at. That's that whole heart thing, but it, you know, without a firm border of what the heart looks like, I just have a hard time visualizing that. So good lateral chest X-ray, some pretty significant rotation there, but looking at the difference in rotation between the top and the bottom, that should be a pretty good indication to you that this patient has scoliosis. So always evaluate your AP or your PA before you repeat a lateral. If you have a patient with scoliosis, you're just never, ever going to get an unrotated lateral chest X-ray. Okay, so that's a good lateral chest X-ray for a patient with scoliosis. Don't go try to correct that. You can, most of the time, get a PA or an AP that is not significantly rotated in as much as the clavicles and the spine indicate rotation. The rest of it's still going to be a disaster. But you're just never going to get an unrotated lateral. Like the upper end here has no rotation. So if you rotated this patient, you tried to correct for the rotation, you rotated the patient to where the lower end showed no rotation, what would you have at the upper end? Rotation. So you just got to take what you can get with a patient with scoliosis. So lateral chest X-ray, we're looking at the posterior ribs. They're not superimposed. Depending on the patient's, you know, their condition here, I might or might not repeat this. Just, you know, if this is an older patient, they're having a hard time standing up, you know, and they almost need the grab bar this low just, you know, for stability. Depending on the patient's condition, I might or might not repeat this. But by the textbook, this is not a good lateral, all right, because we've got rotation. Which way is it rotated? What's that? Left side is posterior. There's your gastric bubble is posterior. The hemidiaphragm is not superimposed. So that's posterior, right? And also we've got the soft tissue covering the apex of the lungs. We need those arms up higher if the patient can tolerate it. And again, sometimes your older patients, they're, you know, you get stiff when you get older, and sometimes they can't get their arms all the way up over their head. So sometimes you just got to take what you can get. Okay, so how about this one? Yeah, this one's just not really going to cooperate a whole lot. So we've got rotation, and we might have a little bit of mid-sagittal plane tilt as well. We don't have, you know, superimposition vertically. Where's gastric bubble?
Yeah, there.
I don't know. Shadow of the heart extends, you know, it looks like it extends beyond the sternum. So if we go back to that, then that would indicate that, you know, if this is true, that the left side is rotated, you know, more anterior. So this is kind of a unicorn in a lot of different ways. No gastric bubble, and I can actually see where the heart is extending beyond the mediastinum. How about that? Soft tissue of the arms. That's just bad soft tissue of the arms. What was that? An attempt at a portable lateral chest X-ray? I don't know. Anybody ever shot a portable lateral chest X-ray? It's pretty rare, but once in a while you'll have to shoot one, and usually those guys are so sick that this might be the best that they could have gotten out of them. The effort should have been there to get those arms up, but if the arms can't, you know, if the patient just absolutely cannot do it, you just need to annotate that, right? The radiologist needs to see that you made the effort, and not just that you, for lack of a better word, half-assed your way through the exam, right? They need to know that you tried, and that needs to come with a little bit of integrity as well, meaning that you don't fall back on that on every exam that was just difficult, to say, a difficult patient, this best patient could do. No, those are the outliers. That's 10% maybe of what you actually shoot. You should be able to get 9 out of 10 patients to cooperate better than that. All right, so mid-sagittal plane tilt, we already talked about that. Again, look at the PA first. What the diaphragms look like is one elevated, natural, or, you know, on the PA, not naturally, but on the PA. So do we have frozen diaphragm? Is it a patient with COPD? Is it a, you know, because with chronic COPD, if the patient has emphysema, you know, in a lot of cases, the diaphragms are going to be at the same level on the PA or the AP, which, because of the divergence of the central ray, is naturally going to separate them, okay? So you can't really do a whole lot about that. So take a look at your PA or your AP, whichever one you shot. Evaluate what those diaphragms look like to tell you what they should look like on the lateral. Okay? We've kind of talked about all that. So, you know, it's good lateral chest X-ray. We already looked at that one. And I'm not real sure what I marked this one as. So some of these I've received from patients over the years, or students over the years. I didn't take notes on them, so I didn't take the history. I don't know exactly what we've got going on. So lateral chest right lateral chest X-ray, you're always going to have separation of the diaphragms. You're going to have that vertical separation of the diaphragms. So where we've got the fundus, the gastric bubble above the diaphragm, if we truly shot a right lateral, then this is going to be normal. We're going to have that. You know, the left diaphragm is going to be, the left diaphragm, turn myself around, is going to be projected. Yeah. No, it's going to be worse. Yeah, it should be below. So what's going on with the gastric bubble above the diaphragm? I don't know. We need, again, to look at the PA to evaluate that. All right. So, and that's what we're talking about here. They're non-superimposed, and why are they not superimposed? I mean, if we look at this one, which diaphragm should be lower, left or right?
Right.
Wait, lower?
Lower. The left. Because of the position of the liver under the right diaphragm, the left diaphragm should be lower. So again, if we have a patient whose diaphragms on the PA are directly across from each other, like what we're seeing here, that could indicate again that the patient's got some sort of insufficiency in aeration of that lung, or it could be, you know, that they've got some sort of obstruction. So how can you rule out obstruction? We talked about on the PA. What are the two, there's two conditions that you might use this specific instruction for. What is that? Expiration, inspiration, expiration, chest X-ray, exactly. So, you know, the radiologist might want to follow up and say, I want to see inspiration, expiration, chest X-ray to see if this diaphragm moves very well, right? So if they're directly across from each other, then you're going to have that separation on the lateral. Just can't get around it. So what to look for, diaphragm not superimposed. Take a look at the gastric bubble. Again, evaluate where the gastric bubble is in relationship to the hemidiaphragms. Anterior to posterior indicates rotation. Superior to inferior indicates tilt. Either the patient's hips were narrow and shoulders were wide, or vice versa. Okay, so what do we see here? Collimation. Yeah, we got half a lateral L-spine, but really the collimation is not quite as bad as what it looks like it is. Lack of inspiration. There's almost no inspiratory effort here. The arms are straight up in front of the patient, so we've got that soft tissue there. So we've got a lot of stuff going on. Oddly enough, the most common positioning error is not all that bad. You know, we don't really have any rotation here, but everything else isn't good. If we had good inspiration, it probably would drop the diaphragms down here, and we wouldn't have the appearance that, you know, we've got such an insufficient amount of collimation. It would still, our exposure field is probably still a little bit big, but it wouldn't be as bad. Is this the best the patient can do, though? Right? I mean, that's always going to be a consideration. Is this the best the patient can do? And take it a little bit further, is this the best the patient would do? You know, because sometimes you're just going to have those patients they're going to do exactly the opposite of anything that you ask them to do. Right. So seated lateral chest X-ray, this is what I was talking about with compression. You can see the soft tissue here kind of pushing up, and that's that compression, or the open quote foreshortening of the anterior lobe. That's what we're looking at there. I also have a little bit of motion, it looks like, on this, or it just could be that sometimes when I save the images from the publisher, they come out very, very small, and then whenever I magnify them, they get a little bit fuzzy. So that looks like motion, but it could just be loss of sharpness as I magnify that image up to put it into this. So pleural effusion. So evaluate that as well on your PA. You know, if you've got separation of diaphragms, well, it's a separation of diaphragms because we have a compressed lung. With pleural effusion, you know, it's definitely going to compress the lower lobe. Remember, we've got two different terms for that we don't, really three different terms we don't want to conflate. The collapse of the lung means what? Or the term for collapse of the lung is atelectasis, right? So don't confuse that. You're going to get that all the way through the registry. Collapse of the lung is atelectasis. What is causing collapse of the lung? Is this lung collapsed? At least partially, so it's partially atelectasis, some degree of atelectasis, right? If we were looking at an image with a massive pneumothorax, or any kind of pneumothorax, do we have atelectasis present? Yes. Yeah, we've got at least a partial collapse of the lung. That's also atelectasis. Okay, so both of those just mean collapse of the lung. What's causing the collapse of the lung in this case is a pleural effusion. And the other one is a pneumothorax, right? So don't, you know, kind of conflate those things. But with that pleural effusion there, then naturally what appears to be the diaphragm over here is going to be elevated. You know, that's not a tilt issue. Again, we don't really have any present rotation. If you look at the vertebra, they're still blocky looking. They don't, you know, the patient's well positioned. It's just they've got a pretty good sized pleural effusion. So we're going to say that this is, you know, we got tilt in this one. So which way are we tilted? There's a right hemidiaphragm, left hemidiaphragm. Which way are we going? Going away, exactly. We're going away, plus we got a little bit of rotation there as well. Okay, so I meant to take all the names off of some of these that were submitted. What about that one? Good lateral chest X-ray? What do you say? Who says good? Who says not good? Okay. All right, so walking through it, we've got some pretty significant rotation. The arms are straight out in front of the patient. And is there any reason to be pretty much right at the iliac crest with your collimated field? The answer is no, it is not. So, you know, this is another one of those that there's just not a whole lot that's really good with this image. It's kind of a bad image. So once in a while you run across a patient that is so barrel chested, and I'm not talking about hypersthenic versus asthenic. You've seen these people that just got these great big thick barrel chests, and you might not be able to fit them on an image. So it looks to me like what they did was they shot a lateral. They said, wow, we cut off a lot. If they would have repositioned this patient perfectly, and you got rotation on this one. The first one, not much rotation, but this one's, you know, it's getting pretty bad. But if they'd have positioned this patient perfectly, would they have gotten him on the second shot? No, he's too big, right? So again, know your equipment, and you know, if the patient would be able to fit on a single image, certainly go back and reposition them, put them on a single image. But if your equipment won't fit the patient on the image, shoot for what it is that you missed on the first one, and don't just go back and repeat and repeat and repeat, trying to make something happen that's never going to happen. Also, marker placement. Some people get kind of uptight about the marker placement. I need it anterior versus I need it posterior. It needs to be on the lateral side of extremity work. You know, just a lot of stuff. My opinion is, you know, it's almost not on this image over here, but my opinion on marker placement is get it on the image and out of the way. Outside of those two things, I don't care. I really do not care where it is, providing it's marking the proper side. You know, if you're shooting, I've got an image that we'll look at when we get to upper extremity. I've got an image where they shot a left shoulder and they put the marker over the spine. That's stupid, right? So in that case, it would be on the lateral side, but you know, I mean, as long as you put it in a reasonable place, it's out of the effective anatomy or the anatomy of interest, and it's on the image. I don't care. I don't care what you do. You could have put it way down here. You could have put it up here. I really don't care. But certainly follow, you know, we used to have a radiologist who used to be an RT down in Jacksonville, and he was really particular, really particular on marker placement and orientation. So, you know, follow hospital or doctor protocol, but if there is none, then, you know, just get it on the image and get it out of the way. All right, so we're just going to muscle through abdomen, if that's okay with y'all, and try to get this done as quickly as possible. So make sure your marker's on the image. Most of the time on the abdomen, I'm going to put the marker, providing it's KUB or an upright abdomen, I'm going to put it in the hip. I'm going to put it at the bottom of the image. If it's a decubitus, then I'm going to put it, generally speaking, if I can see the light, right, I'm going to put it in the light. If I can't see the light, then I'm going to put it in the soft tissue on the elevated side. But I'm going to try to be careful not to put it where it would obstruct, you know, any kind of free air. So outside of the anatomy of interest. So Contrast and density, we want to be able to visualize psoas muscles, the inferior border of the liver, maybe, sometimes that's very difficult to visualize. Important to see the gas patterns, because that's really what we're going to be looking for on especially decubitus. Bony structures, and you want to be able to see the kidneys as well. So artifacts, zippers, snaps, bras if you're shooting the patient upright, things like that. So technique, KVP is going to be a little bit lower because now we're shooting mainly soft tissue, create a lot of scatter radiation. So our KVP, 80, 85. Grid use, because we're going to be shooting through the abdomen, it's all soft tissue on adults, then you really should be using a grid to clean up some of that scatter radiation you create. But there are exceptions to that. If you got a pediatric patient, how thick is a say they're in the NICU, how thick are they? About as thick as your forearm, right? Do you use a grid for a forearm? The answer is no. So, even young, not neonates, I'm probably going to be hard pressed to use a grid for, just because of radiation dose. If you use a 10-to-1 grid, your radiation dose of that patient's going up by 4 times, right? So I'm going to be kind of hard pressed to use it with a kid. Also, consider what you're shooting for. If you get called up to the floor to shoot a KUB for maybe an NG tube placement, what really is it you're looking for? Are you truly looking to see the abdomen? No. You just want to make sure that the NG tube, the Dobhoff, or whatever kind of feeding tube they've got in the patient is below the diaphragm, right? And not curled up in the right mainstem bronchus. So is it imperative? You're not even going to shoot a KUB on that. You're going to shoot with the image receptor more like an upright abdomen, even if the patient's laying down, because you want to see that right mainstem bronchus, right? So is it imperative to clean up all that scatter radiation on that patient? The answer is no. If you have a really, really big hypersthenic patient that's going to throw a lot of scatter, maybe, because you've got to bring out that contrast, but in probably 90% of the population, you really don't need a grid for NG tube placement, Dobhoff placement, or whatever. Photocell is going to be pretty specific to your anatomy, but generally the outer cells. Respiration, what phase of respiration are you shooting your KUBs on? Exhalation? I heard both. I heard inspiration and expiration. So, according to the textbook, all the way through the registry, it's expiration. Have the patient take in a big, deep breath and blow it out. I understand that a lot of radiologists want them shot on inhalation so that it drops the diaphragm and they get more of the abdomen included on the image. That's fine. It's them that's paying the medical malpractice insurance. If that's what they want, give it to them. And I'm not saying that that's going to cause any kind of medical malpractice. I'm just saying, it's really their call. So follow protocol, but all the way through the registry, your answer is exhalation, right? So, and then just make sure that you shoot after the patient stops breathing. Keep your motion, your exposure time as short as possible, so you don't have motion that's just caused by the movement of the bowel. And again, you can use, on portables, you can use KVP to limit motion, right? So when you're shooting portables, remember all the way back to the first semester, and we've talked about it in imaging too, they use a mass timer. So when you adjust the mass on a portable, really what you're adjusting is exposure time, right? It's a set MA, so you're just adjusting the exposure time. So the best way to eliminate some of that motion on a portable is just increase KVP. Okay. All right. So basics: coronal plane for KUB. Coronal plane is going to be horizontal and parallel to the image receptors. Sagittal plane should be perpendicular. The pelvis and the hips, the ASIS should be equidistant, meaning equal distance from the image receptor. Slightly abduct the arms. And that's important just to keep that soft tissue from overlapping. And keep them out from under the covers. All right, because what happens in a lot of cases is that, you know, it's cold, right? So you get your patient perfectly positioned and they've got their arms under the covers and they're laying there for a little bit and their elbows digging into the table. What are they gonna do? Bingo, bingo, they're gonna put their hands across their stomach. Anybody seen this happen? If you haven't, you will. So keep their arms out from underneath the covers. Terry Wood. Y'all know Terry? She used to work at Mother Francis. No? Well, the story would be lost then, because you got to know her personality. But anyway, she had a psych patient that, you know, she got a patient all positioned properly, and I happened to be in Jacksonville. She was doing her clinicals in Jacksonville. She was still a student. So she was real quiet, always polite. Never a cross word came out of her mouth. And she came out of the room, pulled her film out of the processor, and she was cussing, shouting. She was spitting mad. She had a psych patient that had come up from Rusk, and the psych patient knew what was going on. They knew what a KUB was. So she got her all positioned. She pulled out all of her patient care skills and honey sugar babied her, you know, this patient. And went to take the image, and patient had two birds on their head. Yeah, she got flipped off both hands on the x-ray.
Oh my God.
Terry was not happy. So anyway, if you ever meet Terry, you'll kind of understand this story a little bit better. The first time I called over to Mother Francis might have been the first time I ever, and she answered the phone, might have been the first time I ever heard her voice. Medical imaging, this is Terry. And she was a graduate at this point. You know, she was that quiet. Well, the second time I ever heard her voice. First time was on that psych patient. It was hilarious. It was hilarious. All right, so anyway, get them out from under the covers. Make sure that, you know, you don't get any vulgar signs shot at you or anything like that. So positioning, you know, centering, mid-sagittal plane, position the central ray at the iliac crest, and I know that can sometimes be hard to find, right? The crest is hard to find on fit people because everything is tight. On ticklish people because they tighten up as soon as you touch them. On hypersthenic patients because there's extra tissue there. But you gotta find it. If you absolutely can't find it, find the ASIS and then go, you know, 3 fingers above the ASIS and you've got the iliac crest. So probably the most common positioning error I see on KUB is that, you know, you find what you think is the iliac crest, but you're actually on top of the soft tissue on top of the iliac crest, which puts you too high. Now you got the entire anterior pelvic bones. You just don't need to see that, right? Or, you know, the patient that mashes a few times, I can't find that. And next thing you know, you got half of the femur. Okay, get good at finding the crest. You know, get good at finding the crest. If you can't find the crest, you can almost always find the ASIS. All right, so that's going to get you close. Just go about 3 fingers width above the ASIS. All right. So for pathology, you got to know what pathology you're looking at. Right, so is it air? Is it ascites? Is it, you know, does the patient maybe have liver damage? They've got this big distended abdomen. What's causing that? You know, again, if you have a patient who's got liver damage, they may have a distended abdomen, and you can't tell whether that's because of liver damage, I got a beer belly, or do they have a bowel obstruction? Right, so. Telltale signs of bowel obstruction before you take the x-ray.
Very, very hard as it is.
What's that?
It's like very, very hard.
Okay, it's going to be pretty hard. Beer bellies can be too, depending on where that fat buildup is. If it's subcutaneous, it's not too hard, but visceral fat underneath the muscle is, just as hard. How about, do they have an NG tube? You walk in the room, patient's got an NG tube. All right, are they feeding the patient or are they trying to decompress the patient? Well, if they're trying to decompress the patient, that NG tube's going to be hooked up to suction. If it's hooked up to suction, you look at the canister on the wall. If it's full of bile, that patient has bowel obstruction. So what are you going to do with your technique? Are you going to increase it or are you going to decrease it? You're going to decrease it, right? If the patient is, none of that applies really, and they've been in a hospital for a couple of days, you just got to assume that's their anatomy. So then you're going to increase, and the general rule for technique change is usually going to be mass, and it's going to be 30 to 50%, right? And KVP, I find that students have struggle with the adjustment of KVP in relationship to technique adjustment. And the reason is because KVP is so sensitive, 15% change equals 100% change, right? So 30% change in mass is how much in a fraction of a change in mass? A third, roughly a third, right? So how much of a change in KVP do we need to increase the exposure by a factor of 2? 15%, right. So how much of 15 is 5? A third. So those two mean the same thing, right? So 50% change. You ever going to get 7.5 kVp on your control panel? No. Is that half a kVp really going to do anything? No. So 7 to 8 kVp change, right? So your change is going to be 30 to 50%, or the equivalent of that in kVp. If you can't remember 5 to 8, just remember what that would be applied to KVP, 5 to 8%. Okay. All right. So what we're going to look at is, your positioning errors. We're going to look for motion, rotation. We're going to look at the ribs, but more importantly, we're going to look at the pelvic wings. We're going to look at the position of the sacrum within the pelvis, but really the pelvic wings. And we'll just run through this real quick. All right, so your pelvic wings with patient straight AP. Where's my small skeleton? It's way back in the back. Let me grab it real quick. So your pelvic wings are at an angle with the patient laying flat on their back. And if they're straight, they should be symmetric. But if they have any degree of rotation, they're not going to be. All right? So you want to see, as high up in the abdomen as possible down to at least the symphysis pubis. So no rotation, right? But as we have rotation, look at what happens to the appearance. Can you still see? Yeah, you can still see. Look what happens to the appearance of everything, really, the anterior pelvic bones, the pelvic wings, and also the position of the sacrum and the coccyx within the pelvis. So I'll go into an RPO, and what happens to the left iliac wing? Becomes more vertical, right? Much more narrow, as opposed to the downside appears to be elongated. It's not really elongated, right? It just appears that way because it's more parallel to the image receptor. What happened to the anterior pelvic bones? The downside went vertical, right? The upside, anterior pelvic bones opened up. What happened to the position of the sacrum within it? Went towards the elevated side, right? So the easiest thing to look at are these two. If one looks foreshortened, that's the elevated side, right? The patient rotated for whatever reason. Maybe it's scoliosis. Again, if you get scoliosis, you might very well not be able to get rid of any kind of rotation. But basically what we're looking at is what we end the semester, probably end the semester with. That's Jude views. It's pretty much what we're looking at here, right? Just oblique of pelvis. So That's primarily what you're gonna look at. The pathologies we're gonna be looking for are free air, if we're either doing a decubitus or an upright, air fluid levels, again, upright or decubitus. Does the patient have edema? We can see evidence, possible evidence that the patient has valve obstruction by how much air is in their abdomen. So our technique correction when we're phototiming, there really is none. If you adjust your KVP, your mass automatically decreases. If patient has pathology, your AECs compensate for it. So the lines that we're going to be looking for are feeding tubes. Neonatal central lines tend to be UVCs, right? So they clip the umbilical cord, they've got venous access or arterial access, either one, and they can just thread it straight up through. So if you're doing a chest x-ray on a neonate, then what you might need to do is to position, open up your collimators just a little bit to get all the way down to the umbilicus, and then all the way up to the apex of the lungs. So if they're doing a chest x-ray for central line on a PD, that's what I would recommend. And then feeding tubes, we've got NG tubes, duodenal tubes, Taube tubes, maybe even PEG tubes. So positioning would be at the iliac crest, L4, L5, inferior border at the symphysis pubis. I know I have beaten this to death, but highly recommend you never palpate for a patient's symphysis pubis. Ever. Upright abdomen, you want to go 2 inches above the crest, and the easiest way to do that, and this sounds like overkill, but it's not. With the patient laying down, the crest can be hard to find. With the patient upright, it's even harder, okay? So the easiest thing to do is to put the top of the image receptor in at the level of the axilla. Just have the patient raise their arm up a little bit. And again, it seems like it's going to be way too high, but it's not. By the time you have a patient inhale and then exhale, the diaphragm's going to elevate. It's going to be, you're only going to get 2 or 3 inches along, okay? So top of the image receptor, not film, but image receptor at the level of the axilla. Okay, so evaluation, we got a KU and almost a B. If somebody really got in a bind about not being able to see that would be a bladder shot. I would probably not even question that. Just go ahead and send it on. And if somebody grumbled about it, okay, I'll shoot a bladder shot. Okay. So motion. Remember, motion is the main thing that will destroy your image, and you have no control over it. Well, we got mispositioning here too. Assuming this was KUB, I would definitely shoot a bladder shot for that one. If this one was upright, it's still bad because of the motion, but at least you've got the required information on there. Okay, so again, good KU, no B there. But if you look at this patient, this is a pediatric patient. So I would not go back and immediately reshoot this patient. I would probably present this to the radiologist and say, do you need that bladder shot? Just because it's a pediatric patient, what are you going to be shooting at for that bladder shot? Yeah, you're shooting right into their stuff. So I would definitely ask before reshooting that or shooting a bladder shot on it. Now for your next one, if you have to shoot another one, fix it, learn from this mistake and fix it and get it right the next time. What do we have here? Rotation. There's a right marker there, so the patient's rotated towards their right side, exactly. So we've got some rotation there. Starting to get some pretty decent Scotty dogs. So, yeah. So I'm not even going to ask on this one. This is just everything wrong with this one. You got a KU, no B. Only use part of your image receptor. You could say, well, the patient moved themselves off the image receptor. Okay, and they took the collimation with them, right? No, you did this. All right,
It's a magnification.
magnification. Divergence of the central ray magnification. Yeah. So, and, you know, well, anyway. So they've got rotation, they've got mispositioning, you know, it's just it's a mess. Again, pediatric patient, what are we shooting this for? Pediatric patient, could this be a UVC, a central line? What are we doing here? You know, ask before you reshoot these pediatric patients. I mean, this is almost a whole body dose. I'm not saying this. I'm sorry, I said that was central line. That's NG2. That's feeding tube. You know, do they see what they need to see? Did we do this specifically for a feeding tube, for the UVC? Do they want the UVC going, you know, into the inferior vena cava? Is this a line placement? What are we doing? Do you need to reposition this before I shoot it? Because you can see that it's not going upwards towards the heart. It's just stuck right there, you know. So I'd be very sensitive to radiation exposure on kids because they're sensitive to radiation exposure. But we've also got rotation on this patient. So everything's matter with that. But again, I would check with somebody before repeating. So upright abdomen, you know, all that stuff, you know, make sure that you have the patient's feet, their weight evenly distributed on their feet, shoulders and their hips and pelvis equidistant from the image receptor. The arms become probably, paying attention to the arms probably becomes more important on the upright because, you know, you put your arms down to your side. If you're laying down, you know, your arms can be almost anywhere, but because of gravity, if you're upright, they're going to be right there, possibly superimposing the abdomen. So upright abdomen, the anatomy included, make sure you know the radiologist that you're working with. Some radiologists want to see the symphysis pubis on upright abdomen. So what does Merrill say that we do upright abdomen for? Two things. Air fluid levels and free air. Free air. So most of the time, if they suspect the patient has either one of those two, we're going to do, they got a number of different names for it, an acute abdominal series, right, where you do a flat and upright abdomen and PHS. Some places will call that a three-way abdomen, all right? So it means the same thing. So can you see free air under the diaphragm on a PHS? Absolutely, you can, okay? So some of your doctors don't want you to position to include the diaphragm on the upright abdomen. They're already going to see free air under the diaphragm on PHS. So know the docs you're working with. If they want to see the diaphragm, position in the axilla. If they don't want to see the diaphragm, position at the crest. Okay? All right, so upright abdomen, again, we see the bottom of the diaphragms all the way down to the, you know, as much as what we can see. Got a little bit of rotation on this. So this is, you know, this says upright abdomen, but if you look at the position or the shape of the pelvis, this really looks more like a KUB that included the bottom of the diaphragm. With the upright abdomen, the pelvis tilts a little bit and takes on a little bit of a different appearance. I question whether or not this is upright abdomen or if it was put in the book as an upright abdomen because it included the diaphragms. Maybe it's a really high quality phantom positioning dummy, but this is definitely upright abdomen. A little bit of rotation, nothing serious. Okay, so what do we see on this one?
No diaphragm.
No diaphragm. So what's your doctor's protocol, right? So if they need to see free air, this is a repeat, but you might want to consider just using, you know, from maybe the iliac crest up. But we also see air fluid levels, so that might be what they're looking for, right? So again, pediatric patient, you can tell because the pelvis, you know, you got still open epiphyseal plates. You might want to check before you go back and reblast this patient. So, you know, abdomen can be a mess if you have a patient who's full of water. Hypersthenic patient is full of water. You're going to create a lot of scatter radiation. And, you know, I know we stress that the computer algorithm is what shows you your contrast, but if you have a patient who's really, really full of water and they're very big hypersthenic, you're gonna lose some contrast. Doesn't matter how good your computer algorithm is. And that's what we've got going on here. So just understand on those patients, you're just not gonna, this is great positioning on somebody this size. You can see, you know, there's a soft tissue roll there. I bet this patient is quite large, and yet they position. If they could find the iliac crest on this patient, you can find the iliac crest, okay? So find the iliac crest, position, you know, at the iliac crest. Also, though, you know, if you look at this patient, you got a lot of soft tissue out here, but look in here, and we got direct exposure, and I'm not knocking their collimation here, because how do you collimate to this body shape? You just really can't. But this patient looks like they've got some pretty severe osteoporosis, which is going to give you a similar appearance to the hypersthenic patient, right? So again, your computer algorithm's not going to do a whole lot for that. It's a little bit of rotation, but that's not a repeat. So small bowel obstructions and things that you're going to be looking for, especially on upright. If the patient's supine, you're just going to have air. If the patient's upright, you should have air fluid levels. So remember the things that cause obstructions. They may be mechanical, or they may be what we call a non-obstruct ileus. And a non-obstruct ileus occurs post-op. If you've ever had surgery, anybody? Okay, so I'm not going to put you on the spot, but I've had surgery, and they won't let you leave until you fart. Okay, so the reason for that is because the anesthesia, you know, gives you what we refer to as paralytic ileus, and they don't want to send you home until they know that your bowels are moving again. Okay, so what's causing the obstruction? Is it a non-obstruct ileus, meaning it may be medicine-induced, maybe pain? If you've got kids, you know, if you're a mom, you've had children, you know that not only do you get back pain whenever you go into labor, but you get a pain in the abdomen as well, and that's an ileus, okay? If you don't have kids, that's something else you get to look forward to. Or is it a mechanical obstruction? Does the patient have volvulus? Volvulus usually is going to not, well, you're going to have air fluid levels, but at some point the air fluid level is going to come to a point, because kind of like a balloon that you know, the people who make balloon animals, right, use, they'll blow them up and they'll twist to isolate the air into different places, and that balloon comes to a pinch. Okay, so that's what happens with a volvulus. With a intussusception, that's usually in adults, that's usually secondary to a cancer, but in kids it's idiopathic. We don't know why it happens. But what you get is a telescoping of one bowel into the other. So you look at, you know, your markings, your bowel markings here, and what you would find is in the place of the intussusception, you see twice as many. And so it looks kind of like a slinky, and they call it the coil spring sign. So what's causing the obstruction? Is it mechanical for those reasons? Is it a non-obstruct ileus? Did the patient have surgery? What's going on with the patient? Right? So again, more of the same. Possibly a volvulus there. What's causing that? I don't know. That's just too much going on there, and it's a bad image. It's a picture of a picture. So again, position at the crest. There was no reason to include, you know, a third of the femur on each of these. So what's going on with this guy? A lot, really. This was probably portable. It was bad positioning again. Was it a pelvis? If it was a pelvis, then they failed to get the inferior border of that prosthesis, so it's a repeat. Was it abdomen? I don't know. If it was positioned like pelvis, a poorly collimated pelvis at that. So again, just nothing nothing really good with that one. I wish I remember what the history was on that one.
I watched your video on that. It was a guy who ate his leads.
Ate his leads.
Yeah,
Really?
yeah, from his
Telemetry?
telemetry.
Yeah. No, kid, that's a first. I've seen, again, from psych hospital, back in the day before, you know, Bluetooth, the earbuds and all that, everybody walked around with a Walkman, and it was this box. It was powered by 5 AA batteries. And the patients in the psych hospital were just desperate to get out. They'd take those batteries out, they'd eat them, swallow them, just to get out for a while. So you take KUB, I don't remember if that was the case with that patient I was talking about before, but yeah, they'd eat their batteries just to get out of the nut hut for a day. So, you know, we see this over and over again, clip synthesis. This was one that was submitted last year or a year before, and this patient had swallowed something.
They said that they thought it was Orbeez.
Orbeez, that's what it was. Yeah, yeah, so you've seen this one.
Yeah, and it
Yeah.
sucked in the iodine.
Yeah, it sucked up the iodine. And what are Orbeez? You know, they explained it to me, but I don't remember what.
Like little plastic balls that
Little plastic balls?
they grow in
Okay.
size if you fill them with water.
And they're
Okay.
like squishy.
Yeah.
And it's squishy? Okay, you know, when I first saw this, again, I need to put that on here. But when I first saw this, I was like, was it desiccant? What, you know, which, you know, kind of do the same thing, they absorb moisture. Orbeez, okay. Again, more osteoporosis, a little bit of rotation. I think we're beating the dead horse here. Any questions? So, this one I just had to include, because, you know, we've got again, a KU, we don't have KUB, but is that because of bad positioning, or is that because of bad photography? You know, we don't need to see the rail system, we need to see the x-ray. Yeah. So, anyway. Scoliosis, gonna have rotation. Any questions?